Order, order. Welcome to this special Christmas edition of the Health and Social Care Select Committee. And we're delighted to be joined today by the Secretary of State for Health and Social Care, Wes Streeting. Thank you so much for coming. He is accompanied by his two most senior colleagues. We have Samantha Jones, who's the relatively new Permanent Secretary of the Department. Thank you so much, Samantha. Welcome. This is your first, I think, session with us. Welcome. And also Sir Jim Mackey, not quite as new, but equally as important to this conversation. So thank you all three. It is, of course, an auspicious day. We start on the first day of industrial action by resident doctors at a time of significant concern and pressures across the system. We will, of course, come to these points later. But I'd like to start by talking about something very close to our hearts, which is mental health. So you will be aware, all of you, that we have recently published a report into community mental health services with a particular focus on severe mental illness. Yep. And it, of course, surprises no one that we found many holes in the system, too many people being failed, but also some solutions. But I want to start with the funding. The NHS Constitution makes clear that physical and mental health problems should be treated with equal regard, but the medium-term planning framework seems to suggest that the mental health investment standard is changing. So no longer is it going to be incrementally increasing a proportion of spend at ICB level, but instead it's going to be holding firm with inflation. Secretary of State, is that you addressing parity of esteem, and why have you changed that definition?
Well, since coming into office, we have increased mental health investment, and in fact, investment in mental health care has increased by an extra 688 million this year, which has enabled us to hire 8,500 more mental health workers, deliver more talking therapies, and roll out more mental health support in schools as we set out in our manifesto. There is a challenge with the mental health investment standard because of the investment we are putting in, particularly around clearing the elective backlog. I think you heard from my previous evidence to the committee. I am somewhat sceptical about input targets, which micromanage frontline leaders. We're trying to move away from that kind of era of command and control. I think that applies across all areas of health. And I think in mental health, we have been too focused on inputs without properly monitoring outputs and outcomes. The Darzi investigation found that 109,000 children and young people waiting over a year for their first appointment with a mental health specialist. This is despite an increase in spending on mental health services by over 50% since 2019. So it will be the job of the new mental health director to reverse this dynamic. But that doesn't mean we're cutting mental health spending, far from it. In 2025-2026, all systems are forecast to deliver the investment standard as currently defined, and real terms mental health spending was forecast to increase by £320 million. From 26-27, we've set out over the next 3 years, ICBs will be required to meet the mental health investment standard by protecting mental health in real terms, in other words, rising in line with inflation. In addition to that...
Hold on, can I just stop you there with that definition? Right, because that is a different definition. And I would also point out, in that same breath where you spoke about inputs, in that same session, you also said that you were committed to maintaining the mental health investment standard. But the mental health investment standard was understood to mean that the proportion as would rise in line or if not higher than with overall spend. But the spending review makes clear that the spending spent on the NHS is inflation plus 3%. Your new definition for the mental health investment standard is inflation plus 0% because it's being held in real terms. That's what that means, right? Can I ask Jim, have I got that right in accounting terms? Is that correct?
I think the source of the confusion is the spending review and the medium-term planning and the allocations that flow through all of that. Yeah. And that simply takes a baseline and moves it forward from a simple pro rata percentage point of view on every line. That doesn't mean...
So it's inflation plus every line 3%.
Yeah, so you're right in that it hasn't reflected the pure mental health investment standard moving up through the spending period on every line. But in substance, we are still maintaining the standard in next year. The key is what we get back from trusts and ICBs when they return their medium-term planning returns. We expect the shape of spend to have changed and won't be exactly in line with the allocations and the medium-term planning framework. And then we work with people over the next couple of months to make sure things are aligned.
Your definition of the standard is that you are holding spending steady.
We haven't changed the standard. So you're interpreting from those allocations that means something in terms of the standard. As Wes has said, we haven't changed the standard. We are concerned about an over-focus on input measures and a proxy for spending more, meaning better outcomes, because we don't think that's actually the case. I think it's generally not the case in the way that we've been looking at things over the last few years. But we haven't retired the standard, if that's the point.
No, but it is, would you at least admit the way that it's being interpreted is a shift, maybe within its parameters, but it is a shift compared to last year?
I think, in an ideal world, the spending review and allocations would have in every line been in accordance with every specific standard. It's just not the way it was done and agreed with Treasury. So allocations have gone out, but they are indicative. It basically says, here's the spending power, here's what we want you to deliver alongside it, and we expect when everybody comes back on this and on neighbourhood care and on other things, the pattern of spend to have started to change. So I've had a similar challenge on neighbourhood care in that we haven't, in allocations and medium-term allocations, reflected that we expect big shifts in spending line by line. That is what we expect. But we didn't want to be as explicit as that in the allocations, because it is simply a kind of formulaic, here's your spending.
So in terms of, the overall issue here, and you saw it in the Darcy review, we see it over and over again, I hate the word burden, but NHS activity spent on mental health is 20%, and yet we know that the input of funding is at the moment decreasing. The last couple of years there's overall spend, but now with this change it looks like at ICB level that is a possibility as well. Am I wrong to think that the overall spend at ICB level will be, as a proportion, less next year than it is currently?
No, so we're still expecting
to remain the health... So you're expecting proportion will hold?
Yes.
At ICB level?
And again, as Wes has said, we are expecting to deliver the standard in 25-26. There has in recent years been a very significant increase in spend in mental health. But we are all concerned about quality of services in mental health, public confidence, some of the really big catastrophic events that we've all seen, and that we've been over-reliant on the input metric about...
What are the new output metrics that you're planning to put in? Because from what we've seen, you've removed the accounting mechanism, so no longer do they have to account for that spend in the same way. And also we've seen a reduction of mental health output measures. So what is the new output measures that you're going to be introducing?
The new mental health leader who was appointed last week is going through clearance processes currently, so hasn't been announced yet, will lead a process where we will refresh our view over time as to how we get, because the data in mental health isn't as strong as it is in acute services, how we get more of a focus on outcomes. And I think what's really important in this
is waiting time standards one of the things they'll consider, because that was a major recommendation in our report, and there's a huge disparity, isn't it, between mental and physical?
And we will obviously we'll respond to your report and keep it in mind as we're modernising our approach to mental health services, because I do think it is somewhat of an indictment on how the money has been used, that we have put more money into mental health services but we've not seen an improvement in outcomes. I think you're right as a committee to scrutinise, and I think this is kind of increasingly where we'll find ourselves as Parliament in NHS spending, as we're devolving more power, resources and responsibility to ICBs and to providers, and effectively saying we're going to judge you on outcomes. Parliament has a really important role, as will the Secretary of State and the Department for Health and Social Care and the NHS Executive, for making sure that as they are using those freedoms, that they're using them well. So where is the money going? What are the outcomes for patients? The final thing I'd just say on the measure, and as Jim said, we're not proposing to abandon the mental health investment standard or to change the definition. You can compare what we're doing to that measure. But there are important elements of mental health spending not included. So there's 473 million in capital funding available nationally over 26-27 to 29-30. That will support the establishment of 24/7 neighbourhood mental health centres, mental health emergency departments known as crisis assessment centres, expanding neighbourhood health services, eliminating inappropriate out-of-area placements, and increasing crisis accommodation for people with learning disabilities and autism. So there's lots of that spending that isn't counted in the mental health investment standard. And as we're integrating more of the mental health and physical health services together in neighbourhood health centres and services, hopefully we'll see a bit of a blurring of the boundaries between physical and mental health as well.
This is actually very important. So you'll have seen from the report, I mean, we are really inspired by the pilots that we saw, the neighbourhood mental health centres. There are 6. We recommend that you look at increasing the funding for the pilots because we need that data and we need to work out what excellent looks like in all the different settings that they're in. Our concern is because the election interrupted the funding cycle, they're not going to have that full 12 months. So I would urge you to look at that seriously. But we go as far as saying we think this could be transformational across the country and we'd love to see one in every community. But how are we, so what is what you're saying, that if that happens, something like that happens, it would not come from the mental health investment standard money? Are the two not linked? I'm confused by what you said there.
The capital investment isn't counted.
The capital investment.
That's the distinction. And of course, there will be, I mean, where we want to be is making sure that from a patient point of view, that increasingly there'll be less of a distinction between your physical health services and your mental health services, where the two interact and relate together. I'm always struck by the patients I meet who have maybe received a really challenging physical health diagnosis or have experienced a degree of trauma, and the distinction between how physical health services treat and see them and how mental and therapeutic services see and treat them, it feels quite separate, whereas it needs to be joined up. And whether it's things like the Child House model to support child survivors of sexual abuse, which we're rolling out and announcing today, which provides that joined up care around the patient, or thinking about some of the experience we've had with maternity families who've gone through some of the worst ordeals. Yeah, we'll come back to that. But if you're a mother who suffered birth trauma and injury, it is quite likely that as well as the physical scars you bear, you need therapeutic support. It shouldn't feel like you're accessing different NHSs and different parts of the NHS. We've got to join up services.
Thank you, Chair, and good morning. I'd just like to continue on the theme of mental health for a minute and turning to the review into mental health conditions, ADHD and autism. What was the thinking behind collating these 3 almost separate conditions into the one report? They are quite wide areas, and I note that you're looking to cover children, young people and adults in the review as well. What was the thinking behind combining mental health conditions, ADHD and autism in the one report, and is 3 to 6 months the time frame given enough time to carry out the work there that's needed?
So you're absolutely right to draw a distinction, and we do, between mental illness, autism and ADHD. They are different sets of conditions, albeit what we're increasingly seeing, not least because of unmet need or late diagnosis, is a relationship between the two. So it is not uncommon, for example, for people who have struggled to access their ADHD medication or have received a late diagnosis to experience a real deterioration in their mental health as well. But the reason for looking at these 3 things together under the umbrella of a prevalence review is we have seen rising demand for these different services. I think, and this is a supposition, this is why we need to kind of have a stronger evidence base and to pull the existing evidence together. I think that what we're seeing is not just increased demand because of awareness about these conditions, but increasing prevalence of these conditions as well. And I think before we get into all sorts of political debates, ranging from how do we best meet the needs of these different patients, through to what does that therefore mean for the education system in terms of meeting these needs, through to how does DWP respond to rising demand and what does that support look like. Before we get to those wider public policy questions, I felt it was the responsibility of the Department for Health and Social Care to provide an evidence base for understanding prevalence. Because
Sorry, is the idea to understand what's driving a potential increase in prevalence, or to understand if there is an increase in prevalence in the first place?
I think a bit of both. I think it's to understand what's going on, to understand the trends, to understand the drivers, because from a broader health perspective and the way in which we're thinking about our 10-year plan, first and foremost, prevention is better than cure. So if we can understand drivers of different conditions, physical or mental for that matter, and there are steps we can take to prevent people from becoming unwell, we should do that. That's the first thing. And then secondly, we are seeing lots of examples across all three categories of those patients. Unmet need. I mean, when thinking back to my kind of interview on Laura Koonsberg, and being taken down the sort of overdiagnosis rabbit hole, I was kind of flooded with correspondence from people saying, overdiagnosis, I can't even get a diagnosis. And a range of clinical views, ranging from there is certainly a degree of over-pathologisation, which I think was probably the better term to use in that context and that debate, but also clinicians who strongly refuted that assumption and assertion, and similarly from patient and family perspectives as well. And then you get to the wider issues around the stigma surrounding these conditions. So I felt, after my own experience with foot and mouth syndrome on Laura Koonsberg, that actually the best thing that I can do, and my responsibility as the health secretary, was to establish better evidence so we can have a better informed debate, and to make sure that from a public policy point of view we meet these needs.
Is 3 to 6 months enough time to build that evidence base? And I think this is a discussion that has been taking place for a number of years as to why there is an increase in demand. If you visit a primary school anywhere in the country, they'll tell you the uptick in the high needs base and SEND in general is quite significant. Is 3 to 6 months really enough time to grasp what's driving this and to get the idea behind it?
I think so. I mean, the approach I've been taking with a number of these sorts of reviews is let's go as fast as we can so that we can make progress as quickly as possible, recognising that so much of what needs to be done in terms of the public policy response relies on good evidence. But as I've also shown in other contexts, if I've set people a deadline and it's challenging to meet to the extent it will impact on the quality of the work, then I'm always open-minded and responsive. For example, the NHS workforce plan, which we'd intended to get out this side of Christmas, the overwhelming view I had from the trade unions, from the Royal Colleges, from the NHS leadership was actually, if we take a little bit more time, we can actually produce something better. And I would much rather get a bit of challenge at the dispatch box for taking a bit longer than we'd intended than rush something. So that's the assurance I give to you, Jen.
Expect this to maybe drag on for longer than 3 to 6 months?
No, I wouldn't. That's not the expectation I'm setting. I definitely don't want the review team to think, oh, great, kick back.
I've got longer, yeah.
But also, to be fair, the team behind this, and not just in terms of our formal reviewers, but the team of officials sitting behind this as well, are really keen to get into this and to get stuck in, because we recognise just how widespread public concern is about this, the degree to which families are really suffering, because it's not, as ever with so many things, it's not just the person at the centre of mental illness or mental health crisis, or someone who is struggling to get the support they need with autism and ADHD. It's the whole family. It's the wider friendship group. So I think this is something that touches a lot of people. There's clearly a lot of public concern. And my responsibility and our responsibility as a department is to make sure that we are informing public debate so we can start from a somewhat stronger evidence base than maybe I did did when I answered Laura's question.
Thank you. And I'll just quickly, briefly turn on to something completely different, just to throw everyone for a loop. I note in the 10-year plan, this is quite close to my heart, there is really key messaging around poor performance carrying consequences in NHS trusts. My local acute trust consistently scores inadequate on CQC ratings, including its latest, this is Mid and South Essex, by the way, including its latest one on a well-led review, again, and scored inadequate, and it was downgraded from requires improvement to inadequate on A&E, on paediatric care. Some of the findings from the CQC inspectors having to flag that someone was deteriorating, for example, in A&E, truly shocking. It feels as though the impetus for change is placed in the hands of those who potentially have led the trust to be receiving this rating in the first place. What kind of interventionist measures are available and what can be done for trusts like this so that poor performance really does carry consequences?
Jim, do you want to come in on that first?
So it's a good point, and there's a few ways we're going at this. So first of all, refresh the oversight framework to just try and make it more rules-based, more clear, make these sorts of performance issues and governance issues more transparent and more consistent from organisation to organisation. So that allows us to be able to differentiate better who's in trouble and who's not. That's developing over time, so we can start seeing when things are, an organisation might look fine now, but things are starting to go off in a certain place, and then we can get upstream and respond on that. The organisation you mentioned is one of a group of organisations that, if I'm honest, over the last 20-25 years has been a cause for concern for various reasons, and we've got a bit of work going on to say, I think if we're honest, our interventions haven't really worked in those places. There are sometimes systemic or structural issues there that we're not fully understanding, and we'll be having a discussion with Wes and the team in the new year about
what does
that.
Future intervention look like in this space? Because you're quite right, I've lived there my whole life, and I know that it's a couple of decades worth of basically a failing NHS trust that doesn't deliver for people in the area. What does intervention look like to turn that around?
So I'm not going to tell you specifically now today because we're in the process of working this out, and I really don't want to jump to conclusions and do what we've been doing for the last 20-25 years. So we've been relying on mechanisms that mobilise support teams, we escalate the organisation into different levels of oversight, they get improvement directors, we send them people from the GERF team, this sort of thing. And for a lot of organisations that works, but the evidence tells us for 2025 it just doesn't, which tells me, I think, that there's something else going on that we haven't fully acknowledged. We need to be able to really nail that before we then start tailoring support and interventions for those organisations, which is what we want to try and do in January. There's a bit of a pattern for this group of organisations that generally they are a bit more remote, often coastal, don't have the workforce supply that others do, etc. But it's not as simple as that. There
Work in progress, keep us updated. Thank you very much. Alex McIntyre.
Thank you. I'm just going to move us on to the maternity review being undertaken by Baroness Amos at the moment. And sadly, her initial findings will be all too familiar for Gloucester residents who, the ones I've met with, have told me about mothers being sat in bloody bed sheets without being changed, often not being listened to by their doctors. Sadly, we've lost babies to avoidable deaths. That review will come in the new year. I appreciate you haven't seen the findings yet, but will you give a commitment to implementing the findings in full? And what planning is being undertaken by the department at the moment to make sure that the ICBs and local trusts have the capacity and the resources that they need to implement those findings at pace?
So firstly, while we would never commit to something before seeing it, it is always my presumption in favour of implementing recommendations from reviews that we commission from expert people and teams, because otherwise, if you start with an assumption that you're not going to, well, there's no point having the review in the first place. And with this investigation, which I'll be upfront, has drawn criticism, particularly from lots of maternity families that I've worked really closely with. The objective here was to establish as rapidly as possible, at the same time as producing a high quality output, an evidence base for understanding the quality of maternity services across the country, because while there are certain services that have hit the headlines for all the wrong reasons, and those worst cases, my concern is that maternity failures and poor standards are widespread. So we've got to establish that evidence base. Secondly, as Baroness Amos's initial impressions report highlights, we've been drowning the NHS in recommendations from a series of reviews. And I think, having spoken to maternity leaders and frontline staff and families, I think one of the services that we can do as a government is to help the whole maternity service see the wood for the trees, to give people clear and consistent direction about what the first order priorities are to ensure safe care, and then to work through those issues methodically. I've seen examples, including in Nottingham, which has been one of the most high-profile trusts, where frontline staff are on one hand being told to do one set of actions by the Ockenden Review and were then given contradictory instructions by the CQC. Now, that puts staff in a really difficult position, because which way do they look? Do they look to the Ockenden Review? Do they look to the CQC? And then it causes real concern amongst families and the wider community, because they're thinking, well, hang on a minute, that's use unparliamentary language. Does this system and does this service know its backside from its elbow? If people are being told to do contradictory things by kind of experts in this area. So we have responsibility to set out honestly to the public where the system is, to the system to direct them as to what the key actions they can take are, and then to drive improvement. And one of the reasons why I'm establishing the Maternity and Neonatal Task Force and chairing it myself, and including everyone from staff representatives and the professional views right through to families and other experts, is to make sure that we are then keeping a focus on the recommendations and the progress. I would also, no doubt the committee will do that. Parliament should also do that. Because, to be honest, we've seen this kind of fairly widespread actually across the public sector. There's no point having lots of recommendations gathering dust on shelves and then just adding to them with more recommendations or more regulation. We've got to provide clarity, consistency, and then enforce progress and hold people to account if they don't deliver.
On that task force, can I make a request? So I've recently met with one of the brave whistleblowers who spoke out in the BBC Panorama documentary about Gloucestershire Royal Hospital and the maternity failings there, who has been quite honestly shut out from the internal investigations as to what's gone wrong and not listened to by the NHS. And we know that unfortunately the NHS still isn't where it should be in terms of listening to whistleblowers. When we have staff representatives, can we make sure that those who have taken the brave step of blowing the whistle are listened to, as well as those who are currently in the system? Because quite often the people who have spoken out, or quite frankly left the service because they don't feel what the service they were providing was safe, are then not listened to because they've taken that decision to step away.
That is a very good suggestion. I will take that away.
Thank you. I'm going to pass on to Paulette because I think she's got a question on maternity before I come back to it.
I have. Good morning, Wes. My question is relating to the Black Maternal Health Report, which was published yesterday. I want to start by thanking you, because one of our objectives regarding morbidity was actually accepted and will be dealt with in the first quarter of next year. My issue is around some of the others, but we haven't got time for all of them now. The issue is many of those questions or many of those recommendations were quite easy recommendations, such as the one relating to competency training, cultural competency training, which, to be honest, should be mandated and should be quite easy to implement. Could you explain why that was not accepted in the report, please?
Two things. Firstly, over 20,000, I think 20,500 maternity staff have completed the e-learning module to date on cultural competency training. work is underway to draft a new statutory and mandatory training competency framework for all NHS staff, which is going to replace the core skills training framework, which is going to go live in April 2026. And I think the reluctance to commit now to mandating that particular module for maternity is kind of considering that in the context of that wider work being undertaken. I wouldn't read that as a hard no. Is what
the only reason why I've questioned that one is because, and I will shut up because we're really tight on time. I've questioned that one because in October you did introduce some training that is predominantly for consultants and other groupings. So the training seems very bitty, it seems very varied, it isn't co-produced, people don't know whether they're coming or going. And for me, if something is mandatory, it's then done through yourselves at the department and say with the midwives, and also, which is what we recommended, co-produce with families that are going through the trauma. Surely it would give a more inclusive piece of training, whereas at the moment everything that's there, it's just all over the place and you're adding yet another thing.
Yeah, and I think without getting ahead of ourselves, I think the intention is to make sure, because to be honest, the issues around racial inequalities and discrimination are actually quite endemic across the NHS. When you look at the experience of our Black and Asian patients as well as staff, I think, as I've said before, we've got a widespread cultural problem. I would expect cultural competency to be included in the mandatory training competency framework for all NHS staff. And I think that's why there's been a reluctance to commit to something just for maternity. But I'm very happy for us to continue this conversation and to get this right. And it may be that it's your view and the view of others that regardless of what's being offered to all NHS staff, we've got such an issue of maternity that we should have something that's maternity specific. And I'm happy to look at that with you and then report back to the committee.
Thank you. Back to Alex.
Going to move on to industrial action. And before we come to the BMA, I'm going to start with the longest ongoing strike, I think, in NHS history now, which is the phlebotomists in Gloucestershire. What steps are you and the department taking to resolve that dispute so we can get the phlebotomists back into work where they want to be?
So the first thing I would say, Alex, is that it's completely unacceptable that this strike has rumbled on for so long. And this dispute has rumbled on for so long. As you say, it's the longest running in the NHS. I don't think anyone has really covered themselves in glory in this dispute. And when you look at the change the Trust was proposing to make versus the impact the dispute has had, one clearly outweighs the other. I won't say any more at this stage because my understanding is that both the Trust and Unison are in what is, I think, a very constructive phase of dialogue, and I hope that in this season of goodwill that the dispute will end shortly, and I'm very happy to pick this up with you in the new year if that is not the case. But my sense is that both Trust leaders and Unison desperately want to see an end to this, and I don't think we're that far off.
Great, thank you. And moving on to...
Should declare I'm a Unison member, by the way.
Moving on to the subject of the day. Obviously, we've heard a lot about the strikes in the media and the decision by the BMA to go on strike. I guess to push you on a slightly different angle, what steps are you taking to try and resolve the strikes even at this late stage? And also, what steps are you taking as a department to protect patients, including those in my constituency of Gloucester?
Yeah, so I'm not going to waste valuable time this morning sort of relitigating what I've said very publicly and regularly on the BMA and my views on the timing of this industrial action, because they are well known. We met with the BMA yesterday morning, Jim and I and other senior NHS leaders, even at that late stage, to try and see off strike action this week. Obviously, those talks, which went on for about 5 hours, were unsuccessful. I think from where we're sat, when we've got two disputes, there's one on pay, one on jobs, and then we've got the strike action that's sitting beneath it. On pay, our view as a government is we came in, we recognised the deterioration in resident doctors' pay over more than a decade, and we felt a 28.9% pay rise covering the first 3 years was real progress in the right direction for resident doctors. And we were very clear about the BMA that having had 2 years in a row of the highest pay rise in the public sector, we couldn't afford to go further. But of course, we're willing to talk about future years. They haven't done badly out of the DDRB in terms of the recommendations. On multi-year deals, the problem we have, and it was reiterated, I think, yesterday, is that what the BMA are really angling at, and I think fundamentally, even if we put forward a really good jobs package, this is ultimately a pay dispute. What they want is a 26% rise in addition to the 28.9 that they've already had. And when I challenged them on the sort of time period over which that could be delivered, and there's just a gap, a very wide gap, between BMA expectations and affordability. And there's also a fairness thing here, which is I'm responsible for 1.5 million staff in the NHS, not just doctors. We are in really constructive discussions with Agenda for Change with a view to putting together a package which will be a combination of pay structure reform for Agenda for Change, which Unison and RCN have been crying out for, to look at how we improve their pay, which has not improved as well as doctors, and whether we could do that in a deal that would be multi-year. I can't go higher with the BMA on resident doctors than I am with Agenda for Change staff. I do not think that would be fair. And so we're kind of at an impasse on this for the moment. And my frustration about because even now there'll be doctors and have been online who've said, well, look, the government had done nothing on pay, haven't moved on pay. I just don't think that seriously recognises how much we've done. And on jobs, my disappointment is we're always in violent agreement with the BMA on jobs in terms of poor workforce planning, the bottlenecks. The package we put forward I thought was really strong, not just on making sure that we had more specialty training places, bringing forward 1,000 of those to the current round, 4,000 over the next few years, but the emergency legislation we're planning to bring forward, which would deal with UK prioritisation of graduates for those training places, that would have reduced the competition ratio from 4-to-1, where it is today, to less than 2-to-1. I thought it was a really good thing. I don't think that message landed in the last week, but I think there is, and listening to the BMA reps yesterday, I think there is agreement between us and the BMA that's a good thing to do. So where does that leave us? I mean, for the moment, we are entirely focused on getting the NHS through the next 5 days of industrial action. And in fact, I'm probably just as, if not more, worried about the weeks that follow, because frankly, the consultants who are getting us through the next 5 days are the same consultants we would normally be asking to put in extra shifts, extra effort to get us through what is normally the Christmas, New Year peak pressures. They're going to be more knackered as a result. I think we've asked a lot of our consultants, and I kind of feel that weight of responsibility to and for them, and other NHS staff too. It is dicey. I was at the operational centre this morning with Jim. I think we're off to a decent start, but this is going to be a challenging 5 days and a really challenging few weeks. And we're doing everything we can to keep the show on the road. I think the most important message that I want us all to convey collectively as Parliament and the NHS is to the public. I do not want people who need to access healthcare to think strikes are on, I better not try. So if it's an accident or an emergency, people should access A&E. If it's not an accident or an emergency, but people require healthcare, 111 over the phone or online will be there for people and direct people to local services so they get the right care in the right place without adding to A&E pressures. I hope that's given you a helpful overview about where we are with the BMA. I think jobs, broadly in agreement, pay too far apart, and the the sadness I feel actually, especially when I meet with Jack Fletcher, who is a decent person, who cares about his profession. We are in agreement on so many things. If we were not locked in what is an increasingly difficult dispute, we would be making more progress together. And these strikes are going to come at a cost around £250 million and impact on the operational pressures, impact on patients and the whole NHS workforce. And I deeply regret we're in this situation.
Thank you very much. Greg Stafford.
Thank you very much. Continuing on with the strikes, the cost of the July's industrial action was funded from existing NHS budgets. When Sir Stephen was in front of us in September on strikes, he said, but bearing the cost of that being the strikes, would be beyond our ability to cope with. That would be unreasonable for the NHS to do and would have consequences on what we're able to provide. So how much central funding has been given to the NHS to cover the strikes, both in November and now?
Well, so far, not least thanks to the way that Jim and Elizabeth Omani, the Chief Financial Officer of the NHS, have managed with the system to keep costs under control this year. So far, we have managed to absorb pressures of strikes and costs of strikes without directly impacting on frontline services.
Is that correct, Sir Jim?
It is, yeah, so far. And as of this stage of the year financially, we are still broadly on plan. Elizabeth is in discussion with finance directors around the country about how we get some funding out into the system to recognise pressures so far, one of them being industrial action, but without also doing what's happened in previous years, where whatever the cost is, it gets settled up. But as Wes has said, there's no new money into the service that we're getting from Treasury or anywhere else, for understandable reasons. We've had to absorb it internally. We have managed that so far. But as I said last time, there'll come a point where it becomes unreasonable to expect that to happen, but the service has managed it really well so far.
But if money has been rightly saved in the NHS, that money's been spent on strike action rather than improved services. So essentially it has had an impact on frontline services because that money could have been spent on improving X, Y or Z.
There's an opportunity cost, absolutely. And that's why I think the strikes are actually ultimately self-defeating for the BMA and members of the BMA, not just... I know that the sense from BMA members reflected in the ballot, both in terms of turnout and the margin of the ballot response, is to give the government a good kick-in.
Yes,
but
sorry,
that does have an impact.
I do understand.
That does have an impact on the opportunity cost, as you suggest.
So therefore, going forward, given there are probably going to be more strikes, I hope there are you going to, Secretary of State, give a guarantee that in future the NHS won't have to find internal savings to cover these strikes?
We're going to have to keep the costs under careful review. I obviously talk to the Chancellor and the Prime Minister all the time about how we're managing the pressures in the NHS and the impact on services. So those will be ongoing discussions. As we can see across the board, and I think this is one of the points that needs to be considered in terms of the choices and trade-offs we make as a government. We are not awash as a country with cash. And I can't simply knock on the Chancellor's door and ask to access the reserve because it's not in abundance, and there are such a wide range of pressures on the public purse at the moment, on everything from the defence of the nation to crumbling public infrastructure through to the unavoidable unexpected, let alone something like this. And that is the context in which I've asked resident doctors and as well as the wider NHS workforce to understand that as a government we're going as hard and as fast as we can to improve pay, terms and conditions and quality of services. Our job is made harder if we're locked in disputes and strike action that cost all of us, including doctors, because this does, as you've rightly pointed out, there's an opportunity cost of £500 million that has gone funding strikes that could have gone into funding a whole number of things that we and the BMA would agree on in terms of areas to make progress.
Thank you very much. Josh Fenton-Glynn.
Thank you. I'm going to move to a different area. I'm sure you'll be pleased not to talk about industrial action for a bit. I'm going to talk about palliative care. You'll be aware that this committee commissioned an independent expert panel to look into palliative care, and the report wasn't good news. The panel found that as a result of the reliance on charity funding and because there's no minimum service standards in ICBs, the panel found that there's postcode lottery and provision, with poorer and more marginalised communities often losing out. Is that a picture you recognise?
Mm-hmm. Absolutely. And I just want to be upfront about the fact that one of the things that I'm worried about, particularly in relation to the hospice sector, is that in common with the wider voluntary sector, what we're seeing is not only real pressures in terms of costs, but also the ability to raise money through regular individual giving, which is the bread and butter of so much of the voluntary sector, but particularly this part of the voluntary sector. They're seeing a real impact. The sort of the regular direct debits going down and that sort of thing. And so even with the money that we put into the hospice sector, and we've had £100 million already for the sector as a whole in capital funding, 80 million revenue funding for the next 3 years with children's hospices, it's really important that we as the public continue to support our hospices. The government's developing a palliative care and end of life.
Just pause.
Yeah, do.
So your line there was just the public need to do more to support palliative care. That doesn't feel like a sustainable model for funding of palliative care. Well,
let me just, I'll come back to that in a second. I'm about to set out what we want to do with the modern service framework, which is linked to that. I think I've said this before. I am personally uncomfortable with the extent to which the hospice sector is reliant on voluntary donations as opposed to statutory funding. We understand historically why that's been the case and where the hospice movement has grown from, but as someone who has benefited from the hospice sector in terms of end-of-life care for two of my grandparents, both of my grandmothers, over the last 30 years, the service that I saw firsthand and the wider support provided by people like Marie Curie in terms of the hospice at home and the palliative care nurses and teams that go into people's homes, when I look at that, that doesn't feel to me like a nice to have. And it doesn't feel like the kind of, the extra boost that you would expect the charity sector to maybe try and provide to help in the health and care space. It feels like an essential part of a modern health service. But in common with some of the other things we're addressing this morning, there is some distance to travel between where we are and where we want to be. And in loads of those areas, there is a cost attached, and we've got to manage our resources well. And so it's in that context that I say to the public, while I want to be able to do more to help financially the hospice sector, and believe me, if ever I kind of spot some, a capital budget or a capital programme that's underspending towards the end of the financial year, or if there's an opportunity to kind of invest more in hospices, I am like a magpie on this issue and will swoop in and seize any opportunity I can to put more money into hospices. That was one of the reasons we put the 100 million in last year, and I think the 26 million, the 80 million for children's hospices over the next 3 years. The reason we did that was Stephen Kinnock and I were determined to provide that certainty for the children's hospice sector and get away from that kind of, if the money is available, we'll give it to children's hospices. In terms of where we want to be, and as part of that journey towards a better funded hospice sector, we are developing a palliative care and end-of-life care modern service framework for England. That will be aligned with the ambitions set out in the 10-year plan. I can assure you, as and when I'm able to provide more resources for this part of the health and care system and family, I absolutely will do that.
Okay, so I'm now going to go on to workforce within that. So there are currently 78 vacancies for palliative care consultants, or there were when the report was published. That's on top of 132 clinicians expected to leave the profession in the next 5 years. And there are pretty bad training bottlenecks in palliative care particularly. Actually they're getting better, but certainly for the last couple of years. So we've got a workforce crisis here. How close are we to solving it?
So we're working on our workforce plan at the moment. As I said earlier, we are taking a bit more time with that because we want to get it right. This is consistent with the shift we want to see from hospital to community. We want to see more community-based teams. I want people aspiring to a career in the NHS, whether as doctors or nurses or other healthcare professionals. I want them to see the future of the NHS and where the action is and where the excitement is as being in the community, closer to people's homes, in people's homes. I think that particularly applies to palliative and end-of-life care. Jim, I think
just to add to that, going back to the point with the discussion of the BMA, this is part of what we want to try to do with the training system, which again we're in heated agreement on, but try and shift away from a system that prescribes nationally how many slots there are in certain specialties in specific locations, and make it more local, but also try and expand in more community oriented.
Just to pick you up on that point, the problem of the postcode lottery, particularly because there's no minimum service in ICBs, means that we might have to have some form of direction in this in order to make sure that we are fixing that problem.
Yeah. So the MSF will give us more structure to be able to direct more consistency of provision. I had a session with the hospice chief exec yesterday and heard very clearly from them how hard it is to actually continue to function. In the current world, she was working with 2 ICBs that had very different approaches as well, which isn't unusual. So we want to try and bring that consistency, as Wes has said, against which we can then hold people to account, and you can start seeing people commission a consistent model. But specifically on the workforce model, if we can reach agreement with the BMA, this would be a specialty you'd expect to see grow over time.
And there is going to be a cultural challenge there. I mean, one BMA representative I spoke to in the context of the additional specialty places said, look, we want to know where these places are. What we don't want is loads more geriatricians in North Wales. You know, notwithstanding the fact that I'm responsible for the NHS in England, I think that kind of demonstrates to an extent where some of the thinking or some of the culture is around future career ambitions. We will need more geriatricians. Community is a good place to be, and declaring interest, I've got family in North Wales. I'd quite like more geriatricians in North Wales, but I'd like them to be everywhere across the country as well.
In North Wales, because I think I want to get to the broader point. So we've got this workforce crisis, and we've got experienced staff leaving. We've got what looks to be a postcode lottery in provision. We also have the terminal adults end of life bill coming down the pipe, which has an auto-commencement clause after 4 years, whatever the state of social care. As Health Secretary, do you think it's safe to pass legislation with auto-commencement in it after 4 years against this backdrop?
That is a decision for Parliament.
As Health Secretary, do you think it's safe?
The government is neutral on the...
I appreciate that the government is neutral. I'm not asking you whether you think what you think we should do. Do you have safety concerns?
I would like to make sure that were Parliament minded to proceed with the bill and see it through to completion and onto the statute books, I would like to make sure that we have high quality palliative end-of-life care services so that there is a real choice and no one feels compelled to take up an assisted death through the absence of palliative and end-of-life care services. That is not where we are as a country at present.
Do you think auto-commencement puts that at risk?
Yes, please, Permanent Secretary, save me from this line of questioning.
So, as you will be aware, the bill is going through, and we've had 34 amendments from the law sponsor through the committee stage, and it wouldn't be appropriate for us to preempt what is happening in Parliament for very obvious reasons. We will, however, with the Ministry of Justice, ensure that ministers are appropriately briefed on every aspect and every workability aspect of the bill as we proceed and go forward. And I don't think it would be appropriate at this stage to comment any further.
Thank you very much. Andrew George.
Thank you very much. Just so carrying on workforce, and are they taking you back to the statement you made to Parliament about prior to the strikes? I raised the question with you that if there was an agreement on training places and jobs, would you really withdraw that if the strike went ahead? And you said yes. I mean, is that not cutting your nose off to spite your face? I mean, if everyone's agreeing that that's the right thing, it's going to benefit the NHS, it's going to benefit patients, surely you can at least proceed with that whilst you continue your dispute over pay.
Well, there is both a jobs dispute and a pay dispute with the BMA, and while we are in agreement about the need for emergency legislation and UK prioritisation of graduate places, it is a challenging place for a government to be to implement an offer that has been rejected by BMA members. And there have to be consequences for choices. I think my intention at this stage, and recognising that once we get beyond the next 5 days and through what is going to be an extremely difficult few weeks, by my reckoning, between the time of the expiration of the BMA's mandate and the result of their current ballot for a fresh mandate, we've got about 4 to 6 weeks to use well, I hope, with the BMA to see if we can come to a resolution to this dispute, which I think would be in the interest of their members, patients and the NHS as a whole. With that in mind, I think it would be my intention to continue as planned with the preparation for the bill, to bring the bill to Parliament, to get it through as much of its parliamentary stages as possible with the time that business managers have prepared for. And then I hope we will be in a position where we can see the bill not just passed on to the statute books, but put into practice. I will want the BMA's agreement, and I will want an end to the dispute for that to happen. But in the meantime, I think it would be sensible, given that we know that the parliamentary timetable is packed. We also know that it's not for government ministers to just assume that members of both houses will nod it through, and it will require scrutiny. I think it's important we let that scrutiny go through. I also think, by the way, and having listened to what Jack Fletcher and his team said yesterday and listened to some of the feedback from resident doctors, it's quite clear they've got lots of questions about the detail. And also, the thing I've been probably most struck by listening to resident doctors over the past couple of weeks, even where they are in agreement with the government, they still don't quite believe it's going to happen. And I think it says something about, there's just such a cynicism about politics, that actually having a bill that is there in black and white, giving resident doctors the opportunity to see the benefits it would bring, that might have a bit of a seeing is believing effect. And when doctors realise they would actually be able to enter a new application round in the spring, this will make a material difference to their progression. It might just underscore again that this is a government that genuinely wants to work with them on the many, many, many issues that we are in agreement on.
So it's not a total backtrack, it's a sort of semi-withdrawal.
We're going to get the bill ready, get it through, I hope, both houses, and if the BMA is in agreement with us and we can end this dispute, we will motor on.
Okay. You've said, just moving on, you've said that the NHS would collapse without migrant workers, and that's certainly true throughout the NHS. I mean, how do you square the fact that the NHS would collapse without migrant workers with a Home Secretary which is proposing to stop them coming effectively?
Well, where we've been as a government, I think, is recognising that firstly, we want to attract international talent. And that is certainly true in our health and care services. And I'm very happy today to be going across to Unison's rally for migrant workers to personally thank people who give so much to this country and to our health and care services, and to underscore my appreciation and this government's appreciation for what they do. There is an over-reliance on international recruitment. I think that is reflected in the issues we've had with resident doctors on competition for places and the extent to which international medical graduates are competing on equal terms with homegrown talent. We're dealing with that. I think, to be honest, it was reflected in the comments of the leader of the Green Party, who, quite aside from his characterisation of care work, what he was effectively saying is care work is hard work and it's low-paid work, and therefore that's not for us, that's for people from overseas. I really reject that. And that is why this government is improving pay and conditions and putting in place a real career structure for the care workforce, and what I want to see as a care profession, because whether you were born in Brixton or whether you or any other part of this country, or you have come from overseas to work in our health and care services, you deserve good pay, good conditions, a rewarding and job satisfaction, and you deserve the opportunity to progress in a career. And I want to end that kind of culture, which basically says if it's hard work and it's low-paid work, that's not for people like us who are born here. That's for foreign people who we can give low-paid wages to and exploit. I don't think that's right.
But until that happens, and until our own workers are prepared to take on jobs which fundamentally we're talking about minimum wage and very hard work in both social care and care work through the system. Until that's the case, we will still be dependent on migrant workers. And what are you saying to the Home Secretary to make sure that supply is not stopped?
Well, we're working closely with the Home Secretary, and the principle of what the Home Secretary is driving towards, I think there's a couple of things. Firstly, she wants to make sure that we're controlling who goes in and who goes out, and that we are recruiting people that we need. No more, no less. And secondly, she wants to make sure that in terms of some of the illegal crossings and the small boats and abuse of particularly of our asylum system, that we're reducing some of the pull factors to the UK. And that's what the Home Secretary is driving towards.
Okay, well, I don't want to stray into other areas of asylum. So in relation to, you're talking about good pay, decent pay, decent working conditions. In order to achieve your shift from hospital to community, one of the big problems there, in terms of your future workforce plan, and we look forward to seeing that, is ensuring that the jobs are attractive enough to build the workforce to enable that to happen. At present, we're really struggling in that sector, and there are many district nurses, community nurses who will work their socks off throughout their lives and still end up on band 5. I mean, it's given the level of professionalism which you're requiring from them as clinicians out in the community, I mean, how can you ensure that you can build the workforce on that basis?
That's a very good point, and part of the conversation we've been having with the Agenda for Change unions has been around kind of pay structure reform. And Nicola Ranger at the Royal College of Nursing in particular has been banging the drum really hard on this issue of the professional status of nursing, recognising the enormous contribution of nursing to the NHS, and recognising the value of nurses wherever they work in the NHS. So part of what we are currently talking to RCN and the wider Agenda for Change family about is looking at this band 5 to 6 issue. And more generally, I mean, I want, as I said earlier to Josh, I really want people who are thinking about a career in the NHS, not just to imagine working in a hospital or a GP practice, which is where lots of us who are muggles and do not work in the NHS kind of might instinctively kind of think about. Actually, the community-based teams. Some of my favourite shadowing of NHS staff I've done have been with district nurses, and I really want to see that part of the nursing profession in particular grow and flourish, and I really want people who aspire to be nurses to imagine themselves not just on a ward, or in a practice, but to actually be out there in the community, in people's homes. I've seen it firsthand. It is remarkable work, and it impacts on such a wide range of people, often not just the patient in front of you, but the wider family, whether that was the conversation I heard one district nurse having with the wife of a husband whose mental health as well as physical health was really suffering, and the burden that was having on her, right through to the district nurse who was holding the hand of loved ones literally in the final hours of life.
And you may well find, Secretary of State, a letter on these lines might be coming your way in the new year. But right. Dr. Becky Cooper first. Thank you.
Thank you, Chair. So thank you for being here this morning. I want to continue a little bit where Andrew left off with workforce. And it's great, Secretary of State, that you are so incredibly keen on the community. So let's stick with the left shift. So I wonder if you can outline how you're developing our prevention workforce, both in and out of the NHS. So I'm thinking specifically of that community workforce, but also, of course, our voluntary and community sector and our public health workforce, which I appreciate is in another directorate, but is still intrinsic to what we're doing.
Yeah, in a few ways. Firstly, we've worked hard, particularly as a ministerial team, but also with the new leadership we have on both the official side in the Civil Services Department and in the NHS Executive as well, to improve and build on the relationships we have with local authorities and local government, particularly Directors of Public Health, DASs, DCSs, to make sure, and actually even some of the place-based directors in local government, to make sure that we are implementing health in every policy in local government as well. They're part of our workforce planning and that conversation.
Are they, Secretary of State, part of your funding planning? Because one of the conversations is absolutely this is conversation that nobody disagrees with, but you'll appreciate that the funding is still going into the acute sector, and I very much realise why that is the case, because we've failed to prevent people getting sick for so long. We've got a massive acute problem now. But in terms of looking at the funding, at what point are we going to be able to look at the funding and see parallel funding tracks running? I.e., when am I going to be able to look at public health funding and say, okay, that has some teeth, and when is the community funding going to start looking? It'll never be comparable to the acute sector, but when will we start seeing a significant difference in the funding streams?
So we have, in terms of the public health grant, we have been protecting the public health grant and increasing it to recognise the invaluable work that local authorities do. On the prevention side, we've been pulling a whole range of levers at the centre of government, from changes to the law and regulation, whether getting the smoking bill through Parliament or action on obesity and targeting of junk food and those sorts of policy levers, right through to the Chancellor's decision to introduce a gambling levy. Now, that was brilliant in terms of lifting 500,000 children out of poverty. I mean, there is prevention for you right there, primary prevention. But also from a health point of view, regardless of its role as a revenue raiser, raising that money also helps us to tackle gambling harms as well. So this is kind of in common with some of the other lines of questioning this morning. There is no shortages of things we could do with more money. We've got a finite pot. We have to manage our resources well. And
again, just to press you, I appreciate it's very hard to reduce the spend in the acute sector. I'm not naive to that. But at what point during the sort of course of this Parliament will we be able to say, okay, there are significant resources going into the community sector, and public health is massively under-resourced. I appreciate the increase. Is there a sort of progressive economic plan within health to go, okay, we are going to have to run parallel tracks, and that significantly will mean the acute sector either is going to have to take a hit, I don't know how that's going to happen, or we're going to have to redistribute our resources somehow?
We should see this start to come back through medium-term plans, and there's a few tricky elements of it. So we've introduced this unbundling of the block contract that starts to allow the flow of block funds in urgent care into hospitals to start being released, so that if the care is provided somewhere else, that part of the service can get the investment. But there's always a bit of a timing thing here, where you'd ideally like the investment to go in and then start to see the flow fall out. But again, I think our history on this over the NHS isn't great. When we've tried this before and we've made upfront investments, it's often not been related to shifting flow into hospital, so we've ended up increasing costs. So what we're expecting to see is ICBs in their plans start to set out small steps on neighbourhood care and in prevention and using the unbundling of the block to start...
This is in their role as strategic commissioner. This is what you're expecting to see.
Absolutely.
Okay.
And start then seeing patients being treated in other settings. That then reduce income into the hospital sector and fuel further investment in the community services. Okay. The hard bit's going to be the sort of first 18 months, 2 years of it as we start to get things off the ground, prove the work.
Yeah, no, I don't disagree, Jim. It's an incredibly difficult thing to do, and it has been talked about a lot before and it's not happened. So you'll appreciate we're going to keep asking and see if it actually works this time. So in a specific area that we looked at as a committee in the world of prevention and actually clinical services is sexual health services. It was a pretty damning session, to be absolutely honest, and the whole thing is sort of commissioned piecemeal, and the clinicians that run it, the managers that run it, the providers that run it said that it needs to be overhauled. And I know, Jim, when you've been previously, I have raised concerns about at least some public health functions being in local authorities that essentially are, you know, clinical to a greater or lesser extent. Sexual health services very much feel an actual case in point here, and I just wondered what your thinking was around this area. I presume you've read our report.
Me or Wes?
Either of you, feel free. Wes, go for it.
Well, so you're right, and I'll say what I've said before. You know, so when I've been responsible for running these services before, it's very, very hard to work out who funds what, how the money works, who works for who, you know, etc. And it's similar to palliative care. It's a real patchwork around the country.
No, and I appreciate that, Jim. But you are the people to solve this. So rather than admiring the problem, I wonder, are there any solutions, Wes, that you would like to suggest for this issue?
I mean, look, there's been a few things so far. I mean, firstly, to appreciate and respect through actions, not just words, the role that the voluntary sector plays in the provision of sexual health services. And in my early weeks and months in office, that meant, for example, making sure that when we're contracting, that we are recognising the actual costs provided by the voluntary sector and not seeing them as a sort of cheap and easy option, and trying to shortchange them in a way that I think has happened over the years. We have obviously had a big focus on HIV with our HIV action plan, which I'm particularly proud of. But more broadly, UK HSA has been leading work to review our collective approach to sexually transmitted infections. As part of this work, they published their STI prioritisation framework in October 2024, which will allow local systems to work and identify what combination of interventions to focus on, recognising that there is different prevalence and different needs in different communities and different parts of the country. We've rolled out the world's first vaccine programme to prevent gonorrhea, and clinical guidelines have been published by BASH to enable doxycycline to be used as a post-exposure prophylaxis for the prevention of syphilis, which doxypep. Please do not ask me to explain the science.
Okay, Wes, all great. So that's great. We've heard all this in the session.
I think,
all
Becky,
good.
you're asking.
Yes.
I think at the heart of your question is asking.
I'm asking about commissioning the services.
Yeah,
it's a mess.
Is local government the right place for this sort of public health work? So far, the answer has been yes. It's a kind of finely balanced argument, and I think there are some decent arguments for taking some of those services back into the NHS, and I know that's kind of where you're pushing us towards.
Yeah, or I'm just looking for a sort of a sensible way to commission. So at the moment, sexual health services, bits of it commissioned here, bits of it commissioned there. Some clinicians can do some bits, some clinicians can't do some other bits. It's not a sensible, holistic way of looking at
I think that's a fair challenge, and we
Yeah.
should come back to you on that in more detail. And
Great.
we'll go away and take
Have
up
a
the
think,
challenge.
read the report. Lovely. Excellent. So alcohol, Wes, happy Christmas. Can you
I feel
just
very seen.
Excellent. Can you just very briefly outline how as a government, as a responsible government who prioritises people's public health, we can protect people from harm whilst supporting pubs to thrive?
Yeah, look, that is a good challenge. And look, the problem with the problem with alcohol is excess. Generally, in terms of tackling things like obesity and good health, whether liver health or otherwise, and we've got a particular challenge with problem drinking and people who drink to the point of dependency or addiction.
So what should we do?
And we should draw a distinction between those things. Pubs are a good thing, and they are a good thing for health. That's not just my view, it is the view of the Chief Medical Officer, no less, because what pubs do, in common with other community spaces, is provide a place for people to come together and socialise, which is a good thing from a health and well-being point of view.
Right, so I think we've established that the cheap alcohol in the supermarkets is the problem. Are we going to tackle that?
You're leading me towards minimum unit pricing.
I'm trying to be quick because I just want to ask you about the gambling as well. So go.
I think this is a debate worthy of our time that Parliament should get stuck into.
We will come back to
minimum unit pricing. Very quickly, Chair. Sorry, gambling. Should we ban advertising, online advertising for gambling?
That is a matter for my colleagues at DCMS.
But we have a health view on it.
I have a health view on everything. I make sure that they are always put across in cross-government discussions, and there are choices and trade-offs. I'm not aware of any plans to take action in this area.
I would urge you to keep reading our work on this issue. Danny Beals.
Thank you. Just to follow up on sexual health very briefly. Thanks to my colleague for raising it. You're right, Wes. The tools are there now. We've got PrEP for HIV, DoxyPEP, vaccines for hepatitis, gonorrhea, Mpox. We've got a range of tools. We should be winning the battle on sexual health. It's a perfect example of prevention over cure. Yet rates of many STIs are still going up. They're still huge and widening in some instances, inequalities. And as you and as Dr. Cooper has mentioned, fundamentally the system is fragmented. In 2019, this committee recommended a new sexual health strategy. The last government never delivered it, and in 2025 we've again recommended an updated sexual health strategy to bring the system together and build on the prioritisation framework that UKHSA have produced. Do you think it's time for a system-wide strategy on how we realise the potential of these prevention tools?
Well, I certainly think we need to take up Becky's challenge of just thinking about how we are organising ourselves in the commissioning and delivery of services. And you're absolutely right, Danny, as well, to make sure that as we're thinking about that, we are focused on the outcomes and rates and effective access to treatment. But we've also got to do much more on the prevention side, and I'd be very happy to work with members of the committee in that work, not least given your experience in this area before you enter Parliament.
If I may, I was just going to add, one of the elements behind bringing together NHSE and DHSE is to bring policy and delivery closer together. And the regional directors of public health are very much part of the NHS delivery to try and bring this bit together. So we should definitely come back, because it's more about being done locally rather than from a national perspective. It's bringing together that health and local government element.
Yeah. Thank you. Joe Robertson.
Secretary of State, as you'll know, the Alzheimer's Society and the Daily Mail are refocusing attention on dementia, and part of the fight against dementia is ensuring early diagnosis and also ensuring that there isn't the inequality across the country in terms of diagnosis. It's obviously a really important campaign. What can you do and what are you doing to help improve diagnosis of dementia early and to improve dementia care generally?
Yeah, that's a great question, and obviously one of the areas that I think we can be really optimistic and excited about is this science that's taking place in this country, which I think is helping us to better understand dementia and conditions like Alzheimer's, the brain more generally, and I think over the next decade we'll still see real breakthroughs. Nonetheless, in the meantime, I think we should just be honest about the fact that the health system has struggled to support those with complex needs, including those with dementia and their loved ones. Through the 10-year plan, people living with dementia will benefit from improved care planning and better services. By 2027, 95% of those with complex needs should have an agreed care plan. We're also going to deliver the first ever modern service framework for frailty and dementia to deliver rapid improvements in the quality of care and in productivity. And that will be informed by phase one of the Casey Commission, which is obviously expected shortly in 2026. And one of the advances we're making through the NHS app, which will have wider application as well, but will be the My Carer tool that will enable those looking after their loved ones with dementia with permission to make sure decisions are agreed and taken with and by those who best know the patient, and where patients may not be able to take those decisions independently. So in terms of the experience of the person who often carries so much of the load of loving someone and caring for someone with dementia, hopefully we will recognise the status of that person more clearly and help them to better manage the care of their loved one as a partner in their care.
Thank you. Turning to something different, you're currently planning puberty blocker trials, testing on hundreds of children who will receive drugs to alter their sexual development. You've said you're uncomfortable with that, but you're in a uniquely privileged position to do something about it. Will you ensure no children are tested on by having drugs that alter their sexual development?
As Health and Social Care Secretary, as a general principle, I follow clinical advice, and I try wherever possible to resist pressure wherever it comes from and whatever the issue, to overrule clinicians who are better qualified than I am to make clinical judgments about the provision of health services. That's not to say that I can't or would never, but there has to be an extremely high bar for me wading in that way, because I think it would set something of a precedent. On this issue, probably more than any other that I have had to make decisions on as Health Secretary, I have thought long and hard and carefully, and continue to do so, about what the right thing to do is. That started when we were in opposition. We supported Sajid Javid commissioning the CAS review. I think it's one of a number of things that he did in terms of asking the right questions and being prepared to get into this area, which I think has led to a positive legacy and impact after his term in office. The CAS review recommended a ban on puberty blockers. My predecessor, Victoria Atkins, put in place a temporary ban. I not only upheld that temporary ban, I made it a permanent ban on clinical advice. The CAS review also recommended that clinical research be carried out because of a lack of evidence. Now, part of the Pathways trial, which will involve around 3,000 young people, looks at a whole range of therapeutic support and interventions which are not at all related to puberty blockers. In the case of puberty blockers, CAS recommended research in this area. Approval came only after extremely rigorous safety checks and with multiple safeguards in place to protect young people's well-being, including clinical approval and oversight and parental approval as well. There is strict eligibility criteria in place along those lines, and through the decision-making process, the decision to put a young person on trial must then be ratified by a national multidisciplinary team, and there will be close observation. As part of the trial approval process, it went through extremely extensive ethical approvals processes. And that is the base upon which NHS England has commissioned this trial and authorised it to go ahead.
I understand, of course, it's right that you upheld the ban on it originally. So if this trial is to go ahead, it is on your watch and with your consent. There is an alternative. Now, the primary outcome measure of these tests, we learn, is a survey of children who've had, some of them have had, body-altering drugs. There are already thousands of children who've had this Why can they not receive the survey, the primary outcome measure of these new tests, and they form part of the research?
Well, Joe, part of what CAS recommended and will be undertaken is exactly that sort of research into people who are older and have undergone that kind of medical treatment, or indeed other sorts of support, from therapy through to other support from the NHS, to understand their outcomes. At the heart of the decisions that I've made to date, I've had kind of two things in mind first and foremost. Firstly, the safety and well-being of an extremely vulnerable group of children and young people. And secondly, to make sure that I'm following kind of clinical and expert advice and evidence. On the decision to uphold the ban and then to turn it into a permanent ban,
Not a permanent ban, because you're allowing a test so that children who haven't received drugs so far will do under your watch.
A permanent ban on the prescription of these drugs outside of a clinical trial. I've been challenged because I've said in both instances that I was uncomfortable about the ban and I'm uncomfortable about the clinical trial. And both of those statements are true, and both of those statements are consistent. Because when I put in place the permanent ban on puberty blockers, I was confronted with a whole group of young people and their parents who looked me in the eye and told me that I was doing real harm to them, to their lives, to their mental health and well-being. Those are not comfortable conversations to have. And I've had to weigh up at all times whether withdrawing access to this drug or enabling access to this drug is likely to do more or less harm depending on the choice that I've made. And that's the sort of consideration I've had to make in
Can I ask you a question that is about public policy? And that is the potential for a lower age limit, an age limit under which no child can consent. In law, no child under the age of 13 can consent to sexual activity because they don't have capacity, they don't understand what it means. How could children under 13 consent to body-altering drugs that will change or even block their sexual development potentially forever? How can they possibly have capacity to understand what that means? Will you consider a lower age limit by which no child can receive those drugs because they cannot consent?
So two things. Firstly, no child in this study is able to give consent and therefore to be a participant in the trial and receive puberty blockers. In order to participate in a trial, a young person would need to give informed assent, so repeating back to the clinician what the risks are and why they would want to go through them. It is the child's parent or guardian that would need to provide informed consent. Absent of that, a young person would not be eligible to participate in the trial. So I absolutely agree with your assertion that a young person cannot give consent. What they would be required to do is give informed assent, and it is for the parent or guardian to provide consent. Absent of that, they cannot participate in the trial. I am, by the way, very happy for Parliament to continue to scrutinise, to debate and discuss. I do think these are finely balanced judgments, and all the way through I've had to weigh up risk of harm to children and young people, which is why it's not straightforward, why I've lent on clinical advice from people far more qualified than us to make these decisions, but this is not easy. And it is not a comfortable decision, and it's one that I wrestle with on a daily basis.
Thank you very much. So I need to move on to scandals. So it's linked, of course, to the merger that we're seeing between DHSE and the department. First question, very simple. Are we ever going to get an answer to the Hughes report, Secretary of State? It's been 2 years.
Yes, yes, you
when?
are. We are working with our colleagues at the Cabinet Office to address what are a whole number of issues, from the Hughes report through to obviously work on infected blood is now well underway, but we've got other issues. I think particularly about the vaccine injured community. There are a whole bunch of patient groups who have been failed by the NHS
which
historically.
Is what I'm trying to come to. But the Hughes report was meant to be a blueprint for particularly the redress part of this. And as you'll know, many, particularly those who were suffering from Primados, which was a historic injustice, not yet recognised, in fact, I think, by the department as being the injustice that the victims describe it as. But there are many others. The reason I'm specifically asking about the Hughes report is because that was the beginning of the process.
Yeah, no, I appreciate that. So we've committed to progress on initiatives to improve clinical service provision before the 2nd anniversary. We are beginning to see progress already on both sodium valproate, on pelvic mesh, but in terms of broader redress, I'd kind of put this under the same category as a number of other patient groups that we're dealing with, where there is a cost attached to it. There are choices to be made across government, and we're working with colleagues in Cabinet Office in particular to make sure we have a consistent approach to remedying these sorts of injustices.
They do have a lot in common, don't they? I mean, there's sort of three broad areas. One is patients feel unheard, which is often where the problems begin. They also want it never to happen again, and they want investigations to happen in a timely way where recommendations are actually implemented. And then the third part is the redress scheme. So once those have been established, which they often are, they then have to fight all over again to get any kind of compensation beyond a mealy-mouthed apology, which frankly doesn't do it for them.
I couldn't agree more.
Would you agree that those are the three main areas? And is the idea to link those up? Because at the moment they're just not, are they?
Yes, and it's, to be honest, it is the third issue of redress that so often causes the hold-up. The reasons for hold-up are more often than not financial. The reasons for hold-up is because responsibility sits across different government departments. I say this by way of explanation rather than excuse, as you can probably
It's also fair to say, right, like we spent, what is it, £3.1 billion on clinical negligence claims in a single year. Some of that money could be diverted if the other three parts of the system were working well. And I do have a question actually for Samantha, because so part of the Dash Review's recommendations is that Health Watch will sit under you. Now that has raised concerns. You'll have been written to by, I think it was 138 local Health Watch providers who point out that at the moment Health Watch is completely independent, and that is one of its strengths, because people who do not trust the government and people who do not trust the NHS, quite often because they've been failed, feel that there is somewhere completely separate that they can go where their voices will be heard. So while you did answer Secretary of State to their letter, and much of what you have said they agree with, it should be closer, patient voice needs to be embedded, I don't think anyone disagrees with those principles, but you didn't at all address the point about independence. And so my question to Samantha, given that you are the one who is going to be running this as part of your department, how are you going to ensure, if that is the way you are going to go, that it's going to be maintain its independence? Because that's the point I don't feel has been bottomed out yet.
Thank you. I think Dr. Dash's review was very clear in terms of perhaps more of a cluttered landscape around patient safety. and being very clear about who is accountable for patient safety and who is accountable for regulation, and ensuring that there is an independent mirror held up. So we have, of course, the CQC, for example, as an example of that. As we design the future Department of Health and Social Care, which we're in the middle, well, not in the middle, we're starting to do now, we have a very clear requirement to ensure that the patient voice and the independence of the patient voice is incorporated in our approach to patient safety as we move forward. And I'm very happy to come back to the committee as we progress over the next year with more details to demonstrate how that independence is happening in practice.
Work in progress, but there's another area that the independence of which is also being questioned. That's the point of investigations. So you'll be aware the HSSIB was set up following the aviation model. It's only relatively nascent. It's only really only just started, but again, as part of that review, the plan is for that to be sitting under the governance of the CQC. Yeah. You'll understand people who are concerned, and I share that concern personally, that if it's sitting under the same governance, how can we be assured that it is, again, completely independent? In the aviation industry, it is completely independent. And as by way of example, the HSIB, its predecessor that wasn't on statutory footing, did criticise the CQC as part of its investigations. Now, investigation is not regulation. The two are not the same thing. Regulation is meant to stop things from happening in the first place. Investigation is what happens after there's been an issue. How can you be assured completely that by having the HSSIB sitting under the CQC, that there isn't going to be inadvertent conflicts of interest?
Well, firstly, the thing to say is we are not going to incorporate HSIB into the CQC until the CQC is in a fit state to receive it.
Yes, quite.
And secondly, we will make sure through the sort of the governance arrangements and accountabilities that we do not lose that sharp focus on investigation and the expertise that HSIB has that I'm determined to protect.
But do you understand the issue about the independence again? So it's you didn't actually answer that.
But the CQC is independent and is the independent regulator.
But it needs to be independent of all parts of the system, because if the CQC itself is the problem, which as you kind of point out, at points it has been, then how can we be assured that the investigative arm isn't in conflict with one of the arms that it should be investigating?
Sorry.
Samantha?
We are very well versed, as you will appreciate, within the Department of Health and Social Care, of having inquiries and independent inquiries who are part of and separate to the delivery and the oversight of care. So your point is absolutely well and truly understood. We are very, as Secretary of State said, CQC is independent, and we will ensure that how we run inquiries, for example, within the department, is also in terms of the lessons that the CQC have, making sure there is the independence, which is the point that you are making.
HSIB is not the same as inquiries that are under the 2005 Act, are they?
No, I was more using it as an example as to how we can do both things that we do at the moment in the department. We will ensure that is the case within the CQC. It was an example rather than...
I mean, the principle here is that there are tons of checkers in this system. We need a few more doers, and we want to kind of streamline to make sure that we've got the right people doing the right jobs and diverting as much resource to the front line as possible.
Thank you. Ben Conlon.
Thank you, Chair. I'd like to move on to a different area, which is mostly going to involve questions, I think, to give Wes a break, to Sir Jim and to Samantha, which would be about PFI and also public-private partnerships. The plan is to build 250 neighbourhood health centres, I understand, 120 operational by 2030, vast majority via a new PPP model and costing around £1 billion. Of course, we had a lot of money spent on buildings built both for health services and other services with the private sector in the past under the old PFI model. And I'm very interested in getting an understanding of what we've learned from what went wrong before. So my question is, can you set out what you in the department, NHSC and Department of have learned from what went wrong with PFI? Because if you reassure me on that point, then I'll feel much better about the next stage as you take things forward to the PPPs.
Want me to start?
Yes.
We're all keen to avoid repeating the problems of the past. So the model that's being developed through discussions with
Treasury. Stop you right there.
Yeah.
I thought you'd say that.
Sorry?
I thought you stopped right there because I thought you'd say that. I'm not going to ask you about them. I'm not going to ask you about the model. I'd like to go one step back. What were the problems that you found with the PFI that the new model is trying to? But if you could start with the problems, and then we could talk about how the new model would address those. Would that be okay?
Model, yeah. Maybe don't interrupt me again. I'll try and explain it. So in the old model, there were problems with the overall cost of borrowing, the way risk was managed, and the way swaps worked in all of that. The actual risk transfer versus perceived risk transfer, and how that was conducted in the model as well, and then also the cost of variations, how hard it was to change anything. And then for some schemes, because the model changed over time, the way the asset came back into NHS use at the end, or ownership at the end, at the point of termination. All of these things are being addressed in that model.
Are there other problems that you have come across? I mean, I think you've left something significant out, but I don't want to lead you. So I just want to get your view on what else was a big problem, has been a big problem. Samantha, I can see you want to come in.
No, I mean, Jim and I are as one on this. So the important point around this is that it's not bringing back PFI.
Okay, no, focusing on the problems that you
understand. We both had experience of that in practice. So the new PPP model is being led by NISTA, which is independent and co-designed by us for the reason, if I may, around more transparent payment mechanisms, greater contract flexibility to accommodate the change, and stronger monitoring in terms of robust maintenance of the actual asset conditions. So, and the reason I say that in the answer to your question is because those refer to what we would like to do differently in the future rather than.
I may ask you, have you both read the White Fraser report, I presume? Have you read the White Fraser report? No? Okay, well that's possibly the most comprehensive report on what went wrong with PFI. It's only 2 years old, July 2023. I don't see how anybody can take forward what's going on without learning properly from the past. And the number one, and it identifies the problems that you've identified, but the number one problem it identifies, which was obvious from the beginning, is civil servants' skills. The skills that civil servants needed to negotiate contracts were lacking, and the skills that the civil servants needed, the public service needed, to manage the contracts were woefully lacking. And it's partly to do with a completely different mindset, being in the public sector and the commercial sector. I've seen it in local councils. They talk about partnership. And you recognise the fact that the risk balance is often wrong, because partnership means when both sides take risk. But there's not just that. There's the ability to have negotiating skills, to understand negotiating incentives, leverage, what's agreed. Have you recognised the need to change the skill set of the public sector if we're going to do £1 billion worth of PPP deals?
My reference to NISTA was for precisely that point, which is developing these schemes, negotiating these schemes require, as you rightly say, a different skill set, which is why private sector expertise is being harnessed through the NISTA programme and the development in the future to ensure that those people who are designing those schemes and responsible for the negotiation of them take skill sets from lots of different places, which is why I was referencing NISTA. So it is taking that into account. It is a very different skill set.
So are you saying that we're getting private sector people in to train up the civil servants in negotiating, or are we going to be doing what we previously did, was effectively took advice from the private sector all the time while we negotiated, and inevitably they will be acting in different fora for the very people we're negotiating with? So are you training up, are you raising the skills of the civil servants so they're able to do this on their own, or are you going to be using lots of lawyers and people from outside to be alongside them?
I think the model that's being developed by NISTA, supported by us, will actually build on the lessons from the past, including a mixture of both people from outside of the civil service, outside of the NHS, working alongside commercial. And so I'm very happy to come back as it is developed over the next year or so in terms of what does that look like and what is the skill set and how does it actually work together as we go through. I'm very happy to do so.
I think my other observation is that in the time that's passed since PFI was introduced, the skills and capability of the system have changed, and there are probably, I suspect we can go back and check, but there will be more people in commercial functions now in the department and in NHS England than there were before, so we want to bring those together. And also, and in the spirit of, you're right, Ben, to make sure that we do not repeat past mistakes. At the same time, even today and in recent years, we have seen private investment models, whether that's lift schemes in England or whether that's a mutual investment model in Wales, which have passed without controversy, which have not hit the headlines, and have not seen people with placards outside saying no to lift or no to MIM because it's gone well.
But it's gone well. Isn't there a difference between? It's a very important point you make, and I appreciate you making it. And I felt you might. Isn't there a big difference between building something on time, which is meeting a political imperative, and seeing over the years to come what happens, whether there are problems, how they are dealt with, whether the civil servants have actually contracted effectively, whether we end up paying 100% more than we expected to pay? Isn't it too soon? We can judge MIMS and LIFT, yes, they delivered the projects on time, but we can't judge whether they were a success over decades, the way we have now been able to do with the PFI.
So I think in terms of how we're thinking about particularly the PPPs on neighbourhood health, there are definitely things at the forefront of our mind. One is making sure you've got simple and transparent payment mechanisms. The other is making sure that contract flexibility is built in to make sure we've got accommodation changes. And then also the monitoring to make sure we've got robust maintenance of asset conditions, and to make sure that, unlike some other models, the state has the asset. The other good thing, and this is the nicest thing I'll say about the Treasury today, the other good thing about the way the Treasury have set up the approach we're taking to the financing of neighbourhood health is that they have chosen to do public investment in this project alongside the private investment model, so that we can, in real time, look with a like-for-like comparison at what's been most effective. Has one been more cost-effective than the other? Has one developed better quality than the other? Has one been better maintained than the other?
That requires quite a lot of time, and the pressure on building 120 and getting them operational by 2030.
Yeah, we do it, that's why you do it in real time, Ben. And I think having that kind of approach is the right way of thinking about it.
Are you aware of an example where we would have looked at, because I think there's great strength in somebody starting to negotiate and just saying, no, we can't negotiate. You're asking too much, walking away from it, and the government, is there a danger civil servants would feel under so much time pressure that they might not be prepared to walk away or close down projects?
Absolutely not. No, absolutely not. So I think it may be worth just a separate session on this. I think we are in substance in the project.
We're doing an entire inquiry on NHS estates that we launched on Friday.
So we're dealing with all of those issues. Well, just one thing. So I've signed off PFIs and bought one back. So I've learned a lot over the years through those processes. The evidence does, though, suggest that PFI schemes in the NHS generally produce better maintained assets in the long term. So they have generally outperformed the NHS.
If you spent the same amount on the, I mean, forgive me for coming back on that, but if you had spent the same amount of money as a PFI scheme cost to maintain,
there's a long answer to that.
Simply within the public sector, within public sector, if you'd actually been able to make the money available to keep hospitals properly maintained over a number of years, that would be the comparator that you'd need to use. I think it's a wholly unjustifiable statement to make. My last very quick question: are ICBs going to be negotiating and managing these contracts?
Yes or no?
The PPPs, are they going to be negotiated and managed by ICBs, and if so, will they be trained?
Not in my view, no. They'll be.
Sorry, we need to move on. Danny Beals.
Thank you very much. Thank you, Secretary of State. In our 1,000 Critical Days inquiry earlier this year, we looked at one aspect around vaccinations in infancy. These remain below national coverage goals. There's significant disparities by region and by demographic group, which don't seem to be closing. Coverage of preschool immunisations has been declining since 2012, and rates in the UK are lower than Japan, France, Australia, Germany and Denmark. 2023-24 found that coverage had decreased in 14 vaccine coverage measures, and no measures met the WHO 95% target, which used to be an NHS target but was removed from planning guidance in 2025-2026. What's going wrong?
It's a mixed picture on vaccination.
That doesn't sound very mixed. It sounds quite
Well, look, if we take where we've been ahead of this winter, so we delivered over 17 million flu vaccines for this season, which is 170,000 more than this time last year. 60,000 more NHS staff than last year are also getting their jab. We're on track to deliver the 5 percentage point increase in flu vaccine uptake in healthcare workers, which we set out in our urgent and emergency care plan. On school immunisation, the levels are broadly the same as they were last year and slightly better in some cases, and schools with low uptake will be followed up by second visits this week before schools break for Christmas. On the RSV vaccine, almost 68% of 75 to 79-year-olds have been protected against RSV, and we're on track to deliver the 70% target by the end of March, as set out in the UEC plan. On the 2,500 more GPs and the modernised GP appointment bookings are helping with that, but there's more to do. So,
I mean, you described some positives. I mean, some of those statistics are quite low metrics, well below kind of 95%.
Oh, look, I mean, just on that, Danny, just to put all of those positive numbers in context, we are not back to where we were in terms of pre-pandemic levels, and that is the kind of the initial bar we've got to set ourselves. So, I kind of report progress without wanting to sound defensive or complacent, because your central challenge is absolutely the right one.
The government restate the 95% vaccine uptake rate in planning guidance. Was it right to remove that target, bearing in mind where we are and where we've slipped to?
Well, I think regardless of whether it is in the medium-term planning framework, we need to give this the specific focus it requires and make sure that we've got resourcing, because in health visiting numbers, for example, we've seen a 45% decrease over the best part of a decade, and those sorts of things do have an impact. What we are doing is to make sure we're improving, is starting in those areas and with those patient groups where we have the biggest challenge. So the 12 pilots we're running with health visitors from mid-January will be with families who have the most barriers, including everything from ability to travel, language difficulties, vaccine hesitancy.
The pilots are very positive, and we heard the real role of health visiting. I guess we also heard that those pilots are quite slow. Sort of very few areas, potentially taking another 12 months, if not longer, in terms of reaching kind of national level impact. Just turning, you rightly mentioned resourcing. A parliamentary question that was responded to yesterday about NHS England's spend on vaccine and immunisation programmes suggested that NHS England spent in 2021 1% of its budget on immunisation. That fell to 0.64% in 2022 and 0.5% in 2023. And if the overall budget has gone up, and maybe one might challenge the percentages, in real terms it fell from almost 1.5 billion on vaccinations in 2021 to 989 million in 2022, 850 million in 2023. That's lower in percentage and real terms than 2020, 2021. Do these drops in spending on vaccination programmes concern you? Let
me go away with Ashley Dalton and really kick the tyres on all of that, because on one hand, particularly when you spell out not in percentage terms but in actual spend terms, that for me says we need to take a good look, because I would expect across a whole range of areas that with the emphasis we're putting on productivity and modernisation, we would want to see greater efficiency and therefore not always higher spending. The tragedy of the NHS is that it's had higher spending and delivered poorer outcomes.
We are seeing more and more vaccines through scientific advances.
And we've got the new MMRV vaccine, which means from January, the MMR vaccine will include chickenpox for the first time. So there are lots of positive developments, and that could also point to why there are therefore savings if you've got more conditions and confined to a single dose, for example. But I will go and kick the tyres on that, because I think that is a fair question and a fair challenge to ask us.
I welcome that, Secretary. Thank you. And as part of kicking the tyres, I guess we've just outlined that. So we've seen falling spend, we've seen falling rates in many categories of vaccination. More outbreaks has been reported in the press amongst children. One might say that points that the 2023 NHS England vaccination strategy has not worked, unless it predicted, and that was the strategy, which I hoped it wasn't. So as part of kicking the tyres, I hope we might consider updating the national strategy for
vaccines. I think you ask a fair set of questions, and we'll go away and look at that in detail and come back to
Another issue the committee looked at this year was dentistry, and there was big announcements yesterday about kind of overhauling the dentistry system, described as a major overhaul, and certainly there were very welcome changes in there around prioritising the patients most at need. Obviously the sector, particularly when we spoke to them earlier this year, wanted the UDA looked at the cap on the amount of activity that dentists could do, changed. It doesn't seem those were in the announcements yesterday. Just in terms of what these announcements mean, is your sense that this is the end of dentistry reform in this Parliament, or is there more to come?
No, it's definitely not the end. This is part of it. What I want to see is consistent improvement in the quality and availability of NHS dentistry over time. We are starting from such a low bar. And even on our manifesto commitment to deliver 700,000 urgent emergency dentistry appointments, money has been available. ICBs have been making extra appointments available since the 1st of April this year. They're available across the country, but the rollout of that has not been going as fast as I would like and Stephen Kinnock would like, and we are giving that a real push into the new year. So I think the system we inherited in dentistry is, of all of the parts of the NHS, the one that starts, I think, from the worst starting point that we would have wanted. You know, we're stretching, even by kind of usual standards of, well, I wouldn't have started from here, we are kind of stretching. But what I was really struck by yesterday with Stephen's announcement was the welcome it got from the British Dental Association as well, who I have to say, to be fair to the BDA, have had patience of saints. They've worked with us really constructively. They understand the pressures we're under, and they've always, when they've challenged us privately as well as publicly, they've always done so constructively, and I really appreciate that.
Thank you. I would certainly associate myself with that comment about the BDA. Just finally, and it's welcome that there'll be further opportunities to reform dentistry, and you're right about the terrible state that this government inherited dentistry in. Has the final financial envelope for dentistry now been set following the spending reviews? When we saw the Minister previously, it was still under discussion. And if so, is the spending allocation on dentistry bigger, the same, or smaller?
Well, we are currently doing financial planning with the system as we speak as part of the medium-term planning framework. We're getting returns from across the system back now. That will help to inform where we are on investment in dentistry, and no doubt when Jim next come back to the committee, because Sam and I didn't make that commitment. When Jim's back, you can ask him. Thank you.
Thank you very much. Paulette Hamilton.
Oh, thank you. I just want to ask one small question around dentistry. The contract has always been the main issue. What is being done to address the contract that has been the problem from day one?
So part of what Stephen announced yesterday is embedding urgent care into the contract, but I think we're realistic that contract reform is going to be an ongoing process. And look, there are lots of, you've heard me say before, there are lots of problems in the NHS which are not about money and are about modernisation and getting more bang for the buck that's going in and changing the way we do things. In dentistry, I would accept that this is also a money challenge as well. And we're going as hard and fast as we can with the resources that we have, and recognising that we've done relatively well out of the Treasury compared to other government departments, and the Treasury is doing as much as they can given the personal priority the Chancellor attaches to the NHS. But even within that constraint, we are not able to spend our way out of the challenge as quickly as we would like.
Thank you, Wes. Right, now my substantive question is around winter pressures. Now, I always ask about this, so I might bring Jim in to give you time to get some water. Wes, regarding winter pressures, the NHS has been preparing for winter pressures even earlier when we had reports come to the committee than even last year. In your plans, how have your plans for this year been changed based on your experience from previous years. So even though we've prepared earlier, the plans you've looked at, you've tried to change, what has actually changed? Because we're still having this major problem this time of the year.
Yeah. First of all, there's a point about what's the future of urgent care? How does the NHS manage winters routinely without having this big sort of pressure every year? And I think we're going to take some time early in the new year, as soon as we can after peak winter, to try and get our plans together about what this should look like in the future. So we'll get out of this habit of accepting that it's a terrible drama for a couple of months over winter, and it's sort of baked into how we work. So first point, we'll come back at a point in time when we're able to talk about that more fully. This year, it's been much more locally driven, so less kind of central control and submissions, etc. So the national team working with local colleagues in the summer to start thinking about what the plans look like, and materially, on your point, anticipating where there would be problems and getting ahead of, so what would you do then? What happens then when place A falls over, when ambulance handovers stretch out to a certain point, when Cat 2 response runs out to a certain point? Actually, what happens? Who's going to do what when? And using that, rather than trying to work it out at the time when everybody's stretched, everybody's under pressure, anticipate it, get the plans more robustly in place to do that. There's also, we've been working on trying to make the service more consistent in places, using models that work in certain places, and we've got a bit of work going with the College of Emergency Medicine, some chief exec colleagues and Society of Acute Medicine to create a kind of model for the front door. So again, help everybody understand what works, and over time make sure every system has what normally works.
So are you hoping to learn from the mistakes that were made? And I'm not saying mistakes have been made, but from some of the issues that you faced both last year and this year, because could it be that working just on a local basis isn't enough, and it has to be driven more centrally?
Totally, absolutely, and we've got a lot of work to do to make sure that people understand what works in place X, that's a long way from place Y, and then that be adopted more. You know, how does everybody understand what a standard model should be? There's some judgments in that from our point of view about where we should allow people to work out the local nuance versus where we say this is just how it has to happen everywhere. It works, we know it works, everybody just do it. Commissioners need to commission on that basis. And then also, Paulette, you'll have seen all this stuff in recent weeks about flu and the pressure. We've actually had our first contact with winter in a pretty nasty way over the last month. So 2 weeks ago, I really worried about what I was doing, the way flu was accelerating, the pressure in certain systems. That looks like it might be starting to settle, still early days, but might be starting to settle in some parts of the country. And the way the service has held on to handover performance and Cat 2 performance especially, which has been the main focus for the NHS over recent years, I think does give us heart that we've been able to learn from last year and make some adjustments.
I'm going to have to stop you. I've got 1 minute and I need to get this in. It's about vaccine hesitancy. I was a nurse for many, many years, as everybody knows. But the big issue is around the health professionals, allied professionals and others that are not taking the vaccines. Has the time come where everybody needs to wear masks to protect patients? Can I ask Wes to just answer that quickly?
No, the time has not yet come for everyone to wear masks. But what we are absolutely supporting frontline leaders to do is to determine whether, given the pressures they are under, whether it's the right thing to do to ask visitors to hospitals or other NHS or care settings to wear masks to protect themselves and others. There will be places where that's happening. It will be done in an informed way, on the basis of the conditions they're operating under, and most people will happily comply with that. But at this stage, there's no need to kind of mandate mask wearing or to ask everyone around the country to do the same.
Thank you. I'll hand back to the
Last
chair.
questions, Greg Stafford.
Thank you very much, Chair. And I've got 3 questions. Hopefully they're brief, so hopefully brief answers as well. So the first is, as far as I'm aware, the government is yet to publish any timescale or scope for the health bill. So when will the bill be published?
In 2026, certainly.
Can it be a little bit more specific, Secretary of State?
Yes and no, because This is not just my decision, it's subject to the agreement of business managers, but suffice to say we're working at pace to make sure the bill is ready and certainly to make sure that we can complete the abolition of NHS England within the timetable set out by the Prime Minister.
Okay, so spring?
In 2026.
That's not massively helpful. In which case, let's move on to funding. So is the department on track to eliminate deficit support funding in 26-27, given that 92 trusts are still in deficit?
So medium-term plans will tell us how far apart we are when we get them and how we're developing over recent weeks. We won't have eliminated deficit support funding, but we've set up the system so that everybody knows what the rules are. We want to wean off it over time. I think it's unreasonable to expect to get to nil next year or even the year after, but we should see material reductions, and we've seen material improvements in this year so far.
Okay, so essentially that target's been scrapped.
It hasn't been scrapped, no.
But if we're not going to make it in the timetable that you've said.
We set out an objective, and we're making progress against that.
Final question then. Secretary of State, you stated very recently, I think it was earlier this month even, that you will not cut NHS budgets to fund the farmer deal. Can you set out how you are going to fund that then?
Well, the bill is not clear. It is extremely complicated, the way that VPAG works and the way in which the rebate is calculated. So companies have to pay the government a rebate of a proportion of their sales with the revenue distributed to the NHS across the UK. For newer medicines, the rebate rate is set each year at a level calculated to sales to an allowed rate of growth. Under the US deal, the rebate rate for newer medicines will be capped at 15%.
So sorry, forgive me, because I don't have much time. Where is the money going to come from?
Well, we don't know what the cost is going to be.
Yes, but you must have some idea, Secretary of State, and you must have some idea of where that money is going to come from when you have to spend it.
Well, when the Treasury made their allocation to my department in the spending review, they took into account VPAG costs. So if the costs arrive within that envelope, we're absolutely fine. If we're without that envelope, then both within my department and across government, we manage that in the usual way.
So you will cut NHS budgets?
Nope, we're not going to cut.
If the money's going to come from the department,
NHS
where's it going to come from then?
The department has budgets for a wide range of things, including contingencies, and we've also been funded to a degree on VPAG as well. So the challenges, and I'm not trying to be difficult in answering your question, there is just such a wide range of variables in terms of what the number will be, and when that number and the highest plausible number would materialise, which may even be outside of the spending review period. So that's why I am firstly absolutely confident in saying we will not cut NHS budgets to fund this. Secondly, we have been funded by the Treasury, taking into account these costs. And thirdly, should the costs materialise at a scale and at a pace which is unexpected, then we manage those pressures in the usual way, which is either within the department's budget, if we're able to absorb those costs. Where we're not able to absorb costs, of course, we talk to our good friends at the Treasury.
Just one final point of clarification. You said you wouldn't cut NHS budgets. Can you confirm you wouldn't cut social care budgets as well?
Yes, we're not interested in cutting frontline services to fund the US farmer deal, which I have to say, by the way, is a deal that also delivered us 0% tariff for farmer exports for 3 years, and I think has achieved a really good outcome given the pressures and constraints that the negotiating team were operating under.
Thank you very much. We also thank you for your extra time. We enjoyed that together. Order.